The theme of this year's Ed Forum is Learn, Grow, Empower. I attended my first Ed Forum in 2012 in Philadelphia, where I started my journey to learn, grow, empower. If this is your first Ed Forum, I'm sure you will leave St. Louis with more knowledge that will increase your desire to learn more, empower you to advocate for better care and treatments. It is my pleasure to introduce Dr. Andrew Branagan from Massachusetts General Hospital Cancer Center. He has deep-rooted experience with WM since serving as the inaugural WM program manager at the Dana-Farber Cancer Institute. Dr. Branagan was most recently recruited to Massachusetts General Hospital in Boston to focus his clinical and transitional research efforts into multiple myeloma and WM. His research interests include global health and the development of immune-based therapies. Please refer to your Ed Forum packet, meet your 2023 Ed Forum faculty for additional information regarding Dr. Branagan's impressive background and experience. Please join me in welcoming Dr. Branagan to the 2023 IWM Educational Forum. Thank you.
Thanks so much, Ron, and thanks so much to the IWMF for this invitation. Good morning, everybody. I love how interactive you are. It's great. So I'm Andrew Branagan, as you heard, from Mass General Hospital in Boston, and we're going to talk about the basics of WM and some important things to know about WM. And we'll have some time for questions at the end, but if there's something burning, since you all love to speak out, just yell a question, and I'm happy to clarify anything. These are my disclosures. And so, as I mentioned, we're going to make everything related to your WM diagnosis as understandable as possible, summarize some of the symptoms and how to diagnose WM, and then a little bit about the initial approaches to WM management, but you're going to hear more about that with other talks throughout this conference, and then some questions. So we saw in the last talk this picture here, and this is Jan Waldenstrom. And he was a very well-known physician, actually made a lot of medical discoveries. They included things like porphyria, carcinoid syndrome, and in 1944, he first described WM. Now, at that time, not a lot was known about what that disease actually was, and then later on, in 1961, he was the first to actually describe what a monoclonal gammopathy was. And actually, WM is a type of a monoclonal gammopathy. And so really a very impressive background from this man. So what is WM? Well, it's a rare type of a blood cancer. Specifically, it's a lymphoma, or a type of lymphoma called non-Hodgkin's lymphoma. And that type of non-Hodgkin's lymphoma is called lymphoplasmacytic lymphoma, or LPL is the abbreviation. But what's interesting about WM is it's also a plasma cell disorder. So those are diseases like multiple myeloma. And so this is interesting because sometimes doctors who take care of myeloma can be myeloma specialists or they can be lymphoma specialists because the disease sort of falls in between both realms. Macroglobulinemia, so when that term was made back in the 40s, that just means something big is in the blood. Macro means big and emia means in the blood. And so this referred to a large protein. It's a type of an immunoglobulin or antibody, and it's called IgM. And so there's actually dozens of types of non-Hodgkin's lymphoma, and you can see on the right are T-cell types of non-Hodgkin's lymphoma, on the left are B-cell. They can further be categorized as aggressive or indolent meaning slower growing, and Waldenstrom's falls in that category of slower growing, and you can see it on the list. And so it's, as I mentioned, rare, about 2% of all blood cancers. So the incidence is about 3 per million per year. The median age or average age is somewhere in the late 60s to 70. It's more common in males than females, and it's more common in white populations. There's really no strong evidence that there's a specific environmental cause for Waldenstrom's. And it's not passed down in families where you inherit a gene, but there is an increased risk in having a first-degree relative that has either Waldenstrom's or a similar disorder, like another non-Hodgkin's lymphoma, chronic lymphocytic leukemia, or MGUS, for example. And then there's this association with inflammatory conditions. That's really true of all monoclonal gammopathies. So we think that when the immune system is revved up, it's overactive, and that can lead to some of the events we heard in the last talk that cascade and cause a monoclonal gammopathy. And so things like an autoimmune disorder might put you more at risk to get a condition like Waldenstrom's. But there is no proven screening or preventative strategy that we know of at this time. And so, again, to have Waldenstrom's, you need two things, both abnormal cells in the bone marrow, and that has to be with a bone marrow biopsy, and abnormal IgM or monoclonal IgM in the blood. So on the left, you can see a picture from a bone marrow biopsy of some of the cells, and you see a mix here. On the left are plasma cells, and on the right are lymphocytes. And again, they're both part of the clone. They're both abnormal cancer cells. And on the right, you see a picture of IgM. And you can see next to the other antibodies, it's much bigger. And there's much more spots where the antibody can bind. And that can lead to some of the other complications we'll talk about in a couple minutes. So some patients with WM are diagnosed as a complete surprise without any symptoms. It's incidental. They do a blood test and it's found. But others, of course, do have symptoms. So normally, routine blood work can lead to clues that WM is present. For symptomatic patients, the blood test can lead to an accurate diagnosis and assess what manner the WM might be affecting the patient. So let's go over some of these blood tests that are helpful. First is a CBC, or complete blood count. So blood is made up of three kinds of cells, and they're suspended in a solution called plasma. So the three main cells are red cells, and you can see all those small reddish circles. Those are the red cells. White cells, which can look very different, but basically these fight infections, and platelets, which clot the blood. So here's an example of a CBC result you'd see on a computer or a printout, and this is from a patient. And you can see here the WBC, or white blood cell count, is low. So it's 2.3. Normal is about 3.5 or higher. And so you also see the hemoglobin is low, so 10.8. So that means the patient is anemic, meaning a low red count, and normal is closer to about 12 or so. And then you can further divide the white blood cell count. So we know the total count is low, but we don't know which types of white cells may be low. And sure enough, the neutrophils are low. These are one of the most important types of white cells that really help us fight infections. And so the absolute neutrophil count, or ANC in this case, is low at 1.2. Now, another important test is the chemistry profile. This has different names. Sometimes it's called a COMP or a CMP, Comprehensive Metabolic Panel. And there's many bits of useful information in this. You can see the kidney function, calcium, liver function. You can measure electrolytes such as potassium, and you can get some general information about WM. But if you want more information, you actually have to order specific tests. And so here's an example of a chemistry result from a patient. And if you look down, you see the total protein is high. And so oftentimes, this is how patients are found to have a disorder like Waldenstrom's. They have high protein in the blood, and then investigation has to be done to know why is that high. And so one reason could be having a high IgM. So with WM, you really have to measure that IgM. So you can measure a level with antibody levels, but you also have to do an important test called the SPEP. And we saw a picture of this in the last talk as well. It's called a serum protein electrophoresis test, and I'll show you that in a moment. Another test that can be useful with Waldenstrom's is a viscosity. So this tells you how thick the blood is. It's a tricky test because it can be high. A high level means thicker blood, but you may be asymptomatic. And also, there's a lot of automated machines that measure this, and it's not always as reliable. But I did want to mention this can be an important test. So back to the M spike. So M again means monoclonal. So all our antibodies in our blood are supposed to be a little different from each other. And when they're exactly the same or come from a cancer cell, those are called monoclonal. And so sure enough, with Waldenstrom's, the monoclonal protein is IgM. So if you do an SPEP test on a normal person, it should be 0. There should not be any monoclonal protein. And this is how we track the disease with the M spike or IgM level. So in general, a higher IgM means more disease, but this can be different from patient to patient. So here's an example of an SPEP result. So you can see an M spike is detected, so right away you know the patient has a monoclonal gammopathy. And then you can see a list of antibodies on the bottom. And you'll see the IgM is elevated at 2,849. Normal is just about 200 or so. So you can see this is elevated, and it's clonal. Another test that's done when you have an M spike is to know what type of M spike that is, and that's not on this paper, but that's called immunoelectrophoresis, and that'll tell you exactly what type of an M spike. For instance, IgM kappa is the most common. And the other important bit of information you get from this, you'll see, is the immunoglobulin G, or IgG level, which is the first one on the bottom. And this is mildly low at 666. So this is a common finding with Waldenstrom's, where the good antibody levels can be depressed. And if they're significantly depressed, that can put you at risk for infections. So this is an important number to keep track of. So here's an actual picture of an SPEP. So this is a normal, healthy person, and you'll see that there's these little bumps, and the first big bump you see is albumin, because we have a lot of albumin in our blood. And to the far right, you see a little gamma symbol, and there's a broad-based bump. And that's because we have lots of different antibodies in our blood, so it looks like a bump. This is basically blood that's been put on a pad with electricity running through it, and so it's separated by size. And so you see different sizes will show up at different points in this line. When you look at a Waldenstrom's patient, this is an actual patient's M spike, you see here to the right, instead of that small broad-based bump, there's a spike. There's a really tall peaked spike, and that's why it got that name, an M spike, which means there is monoclonal protein in this patient's blood. So again, to properly diagnose Waldenstrom's, you have to do a bone marrow biopsy. That has to show lymphoma in the bone marrow, and there must be monoclonal IgM in the blood. In newly diagnosed patients, there's also a mutation called MYD88, which we heard about also in some of the other talks, and a second one called CXCR4, and I'll talk about that in a couple minutes. Other tests that we sometimes use for Waldenstrom's are cryoglobulins. So this is a condition whereby cooler temperatures impede the blood flow to the kidneys or other parts of the body, and you can see complications such as kidney dysfunction or neuropathy. Cold agglutinins is another unusual complication of Waldenstrom's, where the immune system reacts to the red blood cells and destroys them. So it's a type of hemolysis that happens. There's another complication called amyloid, and this is where the pieces of the antibody called light chains can deposit throughout the body where they're not supposed to and cause organ dysfunction. So to diagnose this, sometimes you need to do certain biopsies. And then if a patient has numbness or tingling, it's very important to have a thorough neuropathy workup. So this involves two things, nerve conduction studies, or EMG, and a look for antibodies against the nerves. So the most common would be anti-MAG antibodies. And we heard a little bit about this concept of Waldenstrom's existing on a spectrum or in phases. So all WM starts as IgM-MGUS, but not all IgM-MGUS becomes WM. So IgM-MGUS means you have an IgM-M spike, but when you do a bone marrow biopsy, you don't see any lymphoma at all. And so as we heard earlier, that's about a 2% chance per year that that could progress to Waldenstrom's, or even more rarely, a different condition. Asymptomatic or smoldering Waldenstrom's means you have an M spike, you do the bone marrow biopsy, and there is lymphoma in the bone marrow, but you don't have any symptoms. Okay, in this case, it's about a 10% chance per year that this will evolve into a symptomatic Waldenstrom's that needs to be treated. And what about the different characteristics that are associated with Waldenstrom's? Different patients have many different symptoms. By definition, if you have a symptom, you need to be treated. So some of these symptoms include anemia or having really low platelets, being severely fatigued, fevers, drenching sweats, or weight loss, severe neuropathy, thick blood or hyperviscosity that's causing symptoms, amyloid disease, cold agglutinins or cryoglobulins, enlarged lymph glands or spleen, or kidney damage from the Waldenstrom's. And here's an example of the thick blood-related eye damage. And so these are pictures of the back of the eye or the retina. This is what an ophthalmologist would see when they look into a scope. And this is an actual Waldenstrom's patient with some hyperviscosity damage to the eye. On the left, if you look sort of near the bottom of the field, you see a lot of splotches. And they're sort of red splotches that shouldn't be there. Those are called hemorrhages. Those are little burst blood vessels throughout the eye. And then if you look to the right, this is a close-up of some of the vessels. And instead of being tiny and smooth, they're engorged. They look like sausages, and that's called sausaging. So this all happens from impeded blood flow to the eyes because the eyes actually have some of the smallest vessels in the whole body. So when you have thick blood, this is the first place you can see symptoms. So if you have a very high IgM, oftentimes what we will do is do regular screening of the eyes to make sure this doesn't develop. And if you do need to be treated, one of the first things that can be done is called plasmapheresis, and this can emergently take down the IgM out of the blood and unthicken the blood, if you will. And so here's the machine. You get hooked up, it takes your blood out, it takes off the IgM and puts your blood back into your body. Another rare complication of Waldenstrom's is when the Waldenstrom cells get into the brain or spinal cord. That's called the central nervous system, and that's known as Bing-Neill syndrome. And so this is a picture of an MRI of a patient who has Bing-Neill syndrome. So sometimes to diagnose this, an MRI is done, and sometimes a lumbar puncture is done to look for cells in the spinal fluid. So just summarizing everything I just said. Oh, yes, we have a question. Good. Shout it out. Back pain. Yeah, great question. It could. Unlike myeloma, really, Waldenstrom's does not usually weaken the bones, so that would be much more of a common symptom for say, a fracture related to myeloma, but you can have all kinds of reasons for back pain. So yes, you can have sometimes deep lymph nodes or masses of Waldenstrom's, but we also a lot of us have back pain, for other reasons, so you never know. But if it's new and concerning, it's definitely worth getting checked out.
I just want to say
Yeah.
that I have no bone symptoms for this back pain.
Got it.
I've had x-rays and analysis of this, and they can't find anything with the bones themselves, so that's why I raised the question.
Got it. Well, if the images are okay, it's probably unrelated and an arthritic type pain. Yeah.
You're talking about thick blood. If you're on a blood thinner because of heart condition, could that mask the idea of?
Yeah, that's a great question. So the term blood thinner isn't really an accurate one. It's just kind of to simplify the term, and that just keeps the platelets and all the clotting happening from the body. It doesn't actually thin the blood.
Well, I'm on an anticoagulant also.
Yeah, so if you think of but when I say thick or viscous, it's kind of like if you think of oil in a car, that heavy viscous compared to water. And so that would still be viscous, even on a blood thinner. It just would be less likely to bleed. So it wouldn't change the ability to do the test and find it. That's a great question. Yep.
One of your earlier slides mentioned calcium. What is that? You want that? Is it a high calcium, low calcium?
Yeah, calcium, so with multiple myeloma, you classically see high calcium because calcium gets pulled out of the bones and there's a dysfunction in the bones. That's quite rare with Waldenstrom's, but sometimes it can help diagnose things like a rare IgM myeloma. Sometimes you get high calcium from renal failure for other reasons. And so it's just one of the electrolytes or substances that's important to look at. But it's not classically high or low, just in rarely in patients with Waldenstrom's.
You might want to direct them to the mics.
Oh, that's right. We were just doing one off burning question, but we will have time at the end, and we should use the mics, because I think people, that's right, are missing this who are online. Okay? Do you want to do one more? Or can you wait for the end? Well, okay, we're going to wait till the end. I think we're almost there. So this just summarized a lot of what I said. I really like this slide. It helps you visualize Waldenstrom's and all the possible symptoms. In the dead center, if you just picture the inside of the bone marrow, and these are the Waldenstrom cells. So as they grow, they can crowd out healthy cells, and you can get a drop in these blood counts. Now, by far the most common reason somebody with Waldenstrom's needs to be treated is becoming anemic. So you can see here in the picture the hemoglobin would go down. Now, there's other reasons to be anemic. So with Waldenstrom's, another thing that the tumor cells sometimes do, they secrete a substance called hepcidin, and this drives down the iron. And so a lot of times if a patient is newly diagnosed and is anemic, you really want to check the iron, because if that's low, you can treat the iron and sometimes resolve the mild anemia without having to treat Waldenstrom's. Then you can see from the IgM being secreted, all of these other syndromes that I mentioned: hyperviscosity, cold agglutinins, cryoglobulins, IgM neuropathy. And you can see the picture throughout the body of the lymph glands. So just as in other lymphomas, sometimes those can get enlarged and cause problems. And you can see Bing-Neal syndrome. And so I wanted to say a little bit about the mutations, because we've already heard about those in the first talks, and I'm sure you'll hear more about them in other talks throughout the conference. So we're talking about genetic mutations, so changes to the DNA inside the Waldenstrom cells, but not mutations you were born with. So these are called somatic mutations. So the two big ones with Waldenstrom's are MYD88 and CXCR4. And so we're learning how these mutations influence how the WM might behave clinically and respond to certain treatments. MYD88 is the most important, and the specific mutation almost always is L265P. And that's in at least 90 to 95% of patients with Waldenstrom's. The second one is CXCR4, and there's actually many types of CXCR4 mutations. And if you add them all together, it's about 40% of patients with Waldenstrom's have that second mutation. And so the first one, this was a big breakthrough with Waldenstrom's, this MYD88 mutation. And you can see it right here in the middle of this signaling pathway. This is a signaling pathway inside of B cells. So normally a B cell uses this pathway when it encounters something new, say a new infection, wants to make a new antibody. It can turn it on, activate it as it wants. What Waldenstrom's does is it hijacks this machinery and it keeps it on constantly. And so it's on, so it helps the tumor cells survive and grow and survive. So this was a very important discovery for Waldenstrom's. And again, 95% of patients with Waldenstrom's have that mutation. The second one is CXCR4. And what this one does is it can actually activate some signaling pathways that are involved in drug resistance. And so this is another important mutation as well. And again, about 30 to 40% of patients with WM have it. And so because of these mutations, sometimes when we think about treatments or trials, you can subgroup patients into having these mutations or not having the mutations or combinations of these mutations. And here is some of the terminology used. So wild type just means unmutated. So you'll hear that a lot, MYD88 WT or wild type. Mutated CXCR4 is also nicknamed WIM, and mutated MYD88 is also nicknamed L265P. That's again, almost always has that exact mutation. Now the mutations with CXCR4 can be two types, nonsense or frame shift. So really the most important one is the nonsense mutation. That has the most clinical significance. And so this table gives a little snapshot of how you might see differences with patients with these mutations. So the table is called genotypic phenotypic association in WM. So genotypic means what's from the DNA. Phenotypic means how it looks like in the actual patient. So on the left side, you see here, would be the most common scenario, a patient who has the MYD88 mutation but does not have a CXCR4 mutation. And then if you look to the right, the second row to the right, this is a patient with the double mutation. So it has the MYD88 mutation and the CXCR4 nonsense mutation. So in that type of patient, usually you see a higher IgM, more bone marrow involvement with WM, and the sensitivity to BTK inhibitors is a little bit less than the patients without that CXCR4 mutation. If you look to the far right, now this is really much less common. We're talking about 5% of the population with Waldenstrom's. These have no mutations, so the wild type, MYD88 wild type and CXCR4 wild type. And these patients tend to have a lower IgM, less bone marrow involvement, and even and also less sensitivity to the BTK inhibitors, even more so than the CXCR4 mutated patients. So how do we manage Waldenstrom's? I think you're going to hear about this in more detail, but just some general overviews. One is that observation is used in a lot of patients. That's about half the time somebody's diagnosed with Waldenstrom's. They don't need to be treated, so it's important not to have a treatment if you don't need it. And then we talked about the reasons for treatments already. And then there's many tools in the toolbox if you do need a treatment. There's monoclonal antibodies. So an example would be rituximab, BTK inhibitors like ibrutinib, zanubrutinib, or acalabrutinib, traditional chemotherapy, cytotoxic chemotherapy like cyclophosphamide or bendamustine. And then there's also proteasome inhibitors, bortezomib, carfilzomib, and ixazomib, for example. And treatment can go on for a long time, be continuous, as with the example of a BTK inhibitor, or it can be for a set period of time, and that's called fixed duration. For example, getting chemotherapy for 6 months. And this is the last slide. I just thought I'd tell you a little bit about some of the ways that patients are tracked during a trial, because you'll hear about a lot of trials during this conference. So response rates are very important. So response rates are the percentage of patients who had a reduction in their measurable WM. And so by far, the most common thing we use to measure the disease is the IgM level. Okay, so the overall response rate could be the patients who have had a response. Specifically, the types of responses are broken down into how much the IgM is reduced. If the IgM is reduced by 25%, that's called a minor response, or MR. If the IgM drops from 50 to 90%, that's called a partial response, or PR. And if it drops by over 90%, that's called a very good partial response, or VGPR. And if it goes completely normal and you can't find any detection of any abnormality with the available tests we have, that's called a complete response. And that's actually a little more rare with indolent lymphomas and with Waldenstrom's. But we're trying to change that with some of the latest trials we're doing. And then you can have stable disease. And this is when you get neither a significant increase or decrease, so the IgM is roughly the same. And then the last term that you probably will hear is progression-free survival. So this is basically how long you have after getting a treatment until you progress. And it's usually written as median progression-free survival. So that's the time at which half of the patients got to the point where they relapsed. Okay? And I'll end there. So thank you so much. This is a picture of Boston, MGH, and that's our team on the right. And I really thank you so much to the IWMF and all our patients, and also to Dr. Mattis, who did the intro talk last year and had some very helpful slides. So thank you all. And we have time for questions. We do have a mic set up that I can barely see. Yeah, go ahead. Yeah, please just walk right up to you can just get in line. You don't have to raise your hand.
Can you hear me?
Yes.
Can you tell us a little bit more about neuropathy in terms of how do we feel?
Sure, that's a great question. So for the most part, neuropathy is slowly progressive. Most people who have an IgM-related neuropathy will first feel it on the bottoms of their feet or their toes. It's usually symmetric, so the same on both sides of the feet, because there's other types of neuropathies. So that's why it's how these differences might be something different, say like a pinched nerve in the back. That would cause neuropathy to be on one side. It can slowly progress over time where it can then go up the top of the feet or up the ankle or even up the legs, and then it can spread to the fingers or the hands. There's some different types. So the classic, more than half of the time, that'll be an anti-MAG neuropathy. And that MAG stands for myelin-associated glycoprotein. So the IgM is actually binding to the myelin, which is the insulating sheath around nerves, and breaking down the insulating sheath. So when you do an EMG study, you see evidence of demyelination, and that's the classic way to find that. And then you do a test in the blood and you find that antibody. There's other types too. I mentioned cryoglobulins can cause a different pattern of neuropathy. That can be more rapidly progressive, so that might happen, just in days to weeks to months rather than years with some of the other neuropathy. And you can have amyloid, can be another cause of neuropathy. So there's many different types, and for different people it can be quite different. But the classic one is a slowly progressive neuropathy, if that makes sense. Thanks.
I also had a question about neuropathy because I'm an Agent Orange veteran, and I've had a large B-cell non-Hodgkin's lymphoma, about 5, 6, 7 years ago. And I'm just wondering, I also had rituximab as a treatment for that, and I'm wondering if that has helped mask my Waldenström's.
So, not a question. At first you said neuropathy, but no question about neuropathy.
Well, I have neuropathy in my hands, and I was diagnosed with neuropathy, and they said that Agent Orange, one of the symptoms of problems with Agent Orange was neuropathy. Got it.
So it sounds like a couple questions there, and thank you for your service, by the way. I'm a former Marine. So sometimes, I don't know about the other lymphoma, sometimes Waldenström's is misdiagnosed as a different lymphoma, and it's actually Waldenström's all along. So sometimes we see that. Sometimes you have other lymphomas that occur in the same patient. Another thing that can happen is the Waldenström's can transform into an aggressive lymphoma over time. But Agent Orange for sure is related to non-Hodgkin's lymphoma. So hopefully that's you have that as a service-connected condition.
Yes.
Okay. And then the question about the neuropathy, it's possible. So it could be from the Agent Orange, but you would for sure need a thorough workup. So you'd want to have an EMG study and all the sensory neural antibody testing done to see if it fits a pattern that might be different from Agent Orange.
Thank you.
Yep.
Thank you, Dr. Mattis, for such a clear, wonderful...
Oh, it's Branagan. Dr. Mattis is my friend. I'm Dr. Branagan.
Dr. Branagan. Oh, why are we looking at that?
But
Dr.
that's a good
Branagan.
compliment, because he's a great man.
All
Thank
right.
you.
But you gave us a really clear picture of the disease. At support group meetings, patients are often comparing their numbers, especially for IgM. I wonder if that always corresponds to how they're feeling or how the disease has progressed. It seems like some people have terrible numbers, but seem to be doing quite well, and sometimes it's the opposite. Can you explain?
Yes, I'm so happy you brought up this point, because I didn't spend a lot of time to talk about it. But with other diseases like multiple myeloma, it's a one-to-one correlation. The higher the monoclonal protein, the more disease you have. So you have a big M spike, you're going to have a lot of myeloma in the bone marrow. It's almost always like that. Waldenström's, absolutely not. It's a very different disease. And some of that has to do with these mutations, some of this has to do with other factors, but you can have a tiny bit of disease and lots of IgM, and you can have a lot of disease with hardly any IgM. So there is not a good correlation. So nobody should make that automatic assumption that if you have a lot of IgM, you have a lot of disease. And sometimes a lot of IgM causes no symptoms. Sometimes it can cause thick blood and other symptoms. Sometimes just a tiny bit of IgM can cause really awful symptoms. So I have patients who have a normal IgM and devastating symptoms. So really, the absolute number is not the most important factor for Waldenstrom's. Thank you.
Hi there. Could you tell us more about neuropathy as it applies to what the cause of the neuropathy is? Does it matter in terms of treatment, whether it's an IgM neuropathy or some other cause, a pinched nerve or whatever?
Yeah, good question. So it would matter because if it's from the Waldenstrom's, the only way to treat it is to treat the Waldenstrom's. So if a patient that's their only symptom, that would be the reason to go ahead and treat the Waldenstrom's if it's the neuropathy is from the IgM. So that's why it's so important. Because if say it's from a pinched nerve or a carpal tunnel or some other reason, you don't want to falsely go ahead and put somebody on chemotherapy. There's other ways to mask neuropathy with certain drugs, but you really, to get at the root of the problem, if it's being driven by IgM, you really want to get the IgM level down, and that's by treating the source of the problem, and that's the Waldenstrom cells.
May I ask a follow-up? So if it's multiple causes of neuropathy, though, and you're treating the IgM neuropathy, are there any harms in treating other types of neuropathy or any different directions you'd go in treatment?
No, you'd
If
want to
there's
treat.
also a pinched nerve or whatever?
Yeah, you'd want to go ahead and treat everything you could. So, for
Okay.
instance, someone might have diabetes, and they have some neuropathy from that. You'd want to control the diabetes. If it was from a pinched nerve, you'd want to control that pinched nerve. That's right. There's no reason you can't do multiple things at the same time.
Okay. And the treatments are this, the other types of treatments, the non-medical treatments, in terms of physical therapy and all, would be the same, whether it's demyelination or some other type of cause?
Not always. So sometimes balance is a big problem with demyelination. So, so the physical therapist would work on balance training, whereas other neuropathies might be more strength, and you have to work on strength training. And some of the medications I was alluding to can mask the discomfort that sometimes comes with neuropathy. Sometimes there's burning pain. Drugs like Lyrica, gabapentin can help with. So sometimes those can use in conjunction, but you don't want to just mask the symptoms without getting at the source if you ever can.
Okay. Thanks for your patience for my multi-part question.
No, great questions.
Okay, you kind of answered my question. What you said earlier, though, was a dropping IgM does not necessarily mean that you can't have progression of disease. Is that correct?
A dropping IgM. So that's even a different story. I'm just saying the level of IgM in a given person is very different from
Right.
one person to another.
Right.
Usually they track,
Okay.
but once you have your own level, and that's meaningful to you, that's why we use this for trials and for measuring responses. Usually, that does mean that you're responding, but there are exceptions. So you can develop complications like amyloid, where the light chains would then go up and the IgM wouldn't necessarily go up. You could develop swollen glands or a bulky liver or spleen, not necessarily related to the IgM, but in general, for any given person, the IgM is the best marker. We've actually compared the M spike to IgM, and IgM was a little better than using an M spike. Unlike multiple myeloma, where they use the M spike to track the disease.
Okay. My other question is regarding the IgM. So does IgM progressively go down, or is it going down because of disease or because of medication? Can medication affect your IgM falling?
Yeah,
No, I'm sorry, I meant IgG, not IgM.
Oh, IgG you're
Yeah.
talking about. Okay.
Because mine was normal, now it's
Yeah.
going down. So I'm just wondering, is that disease, or could it be from medication?
Got it. Great point. The IgG, it can be both. So some people, even with MGUS, have a little bit of a low IgG. In general, the more disease, the more that gets impacted.
Okay.
But unfortunately, certain treatments can make that worse. So treatments target the cells of the Waldenstrom's are similar to some of the cells that make antibodies, B
Yeah, that's
cells.
what I was thinking.
Right? So things like Rituxan, those can drop your normal B cells, and then your normal IgG can get worse.
Right.
So it could be a mix of both in that case. And sometimes, unfortunately, you can have an excellent response. The IgG does not always get better. So even if your IgM's causing trouble, you go through your treatment, the IgM gets a lot better, you have an incredible response, that IgG often will stay low.
So that's why so many people are getting it monthly still.
That's right.
Okay. And one last question. When you get sick, isn't the first responder the IgM? Like normal illness, viruses, things
Yep.
like that, right?
Yep.
So that's also going to affect your IgM count when you get it done if you just had a viral infection.
Yes, so that's an interesting point. That's why when you have a high IgM, you always have to do that SPEP test to know that it's monoclonal, just in somebody that first comes in and has a high IgM level. Because you can have a high IgM for inflammation reasons, or you're exposed to a recent infection, and so that can go up. With somebody with Waldenstrom's, yes, you can temporarily have what's called a polyclonal increase in your IgM. So your good IgM can go up a little. That's usually a temporary thing, so you would just repeat the test in a month or so, and if that's the case, that should then go back down.
All right, and does it go up when you get your vaccinations?
It usually does not,
Okay.
but it can. It can temporarily go up from a vaccination.
Okay, thanks.
It can temporarily go up from certain treatments too, like rituximab can shoot your IgM up, for instance, and IVIG can sometimes temporarily increase your IgM.
Okay, great, thank you.
Welcome.
Hi, Dr. Branagan. I'm asking a question on behalf of the virtual audience, and thank you to our virtual attendees for tuning in. How frequently do second primary malignancies develop in patients with WM irrespective of treatment?
Yeah, that's a great question. This can be actually up to 10-15% of the time or so. And so we looked at a series of patients years ago and found this to be the case. Yeah.
Yes, you described a correlation with Agent Orange. I was exposed to PCBs about 50 years ago. Would that be an issue as well? And secondly, why would it take so long to manifest itself?
So I didn't hear the question. You were exposed to what?
I was exposed to PCBs several times 50 years ago. Would that cause my WM? And if it did, why does it take 45 years to manifest itself?
Yeah, so yes, it could be. And I think a lot of the environmental exposures we probably don't fully understand yet, because clearly we have something like Agent Orange where it's been researched a lot, and we know for sure there's a lot of chemicals in our environment we're bombarded with, so we don't know the answer. But why it takes so long is because these are indolent, slow-growing lymphomas. And so the hits that happen take years and years to develop, to go from the next stage, from an early precursor state to an MGUS to an asymptomatic state to a full-blown state. So that process takes a long time, is why.
Thank you, and thank you for an excellent presentation.
Oh, thanks.
Sorry, we have another question, if that's okay, from the virtual audience. What does it mean if BTK inhibitors, such as Brukinsa, make symptoms worse? Why does it cause so much bleeding?
Why does it cause so much?
So much bleeding. Bleeding?
Oh, bleeding.
Bleeding.
Got it. Well, hopefully they won't make symptoms worse, then they shouldn't be used, right? The whole point of treating Waldenstrom's is to have less symptoms. So in general, the BTK inhibitors are very well tolerated. There's different side effect profiles for all the different BTK inhibitors. So that increased risk of bleeding is unfortunately present for all of them. It is a slight increased risk, so if somebody is having significant bleeding, they should stop it right away. In general, it's just major things like surgery. You would want to hold it for a major surgery, and some people get some bruising and bleeding, mild bleeding if they bump themselves, things like that. But for significant bleeding, you would want to stop it.
Are your children genetically inclined to get WM down the road too, or no? Hereditary or?
Yeah, so in general, no. So it's a sporadic disease. There are a very rare families where it really runs in the family, and those families are being studied. But as I mentioned earlier in the talk, there is a increased risk of having a first-degree relative, but it is not from a mutation that's passed on. So we don't screen children because that is still quite uncommon. Even though there's an increased risk of a rare disease than the general population, it's still a low risk overall.
I have been taking a BTK inhibitor since last fall, and I started getting really bad headaches, and so they reduced the dosage from 320 milligrams to 180, and I'm just wondering what would be causing the headaches?
Yeah. So like all medication, there's different side effects. Unfortunately, there's no perfect drug that has no side effects yet for Waldenstrom's. I wish we could find one. I wonder if it's acalabrutinib you're taking. That's classically, that gives you a headache. That's one of the most common. Oh, okay, it is. So that's a little less common with Brukinsa. But yes, that can happen from all the BTK inhibitors, unfortunately. And sometimes caffeine helps. And sometimes, as you did, you drop the dose and it helps. Yeah.
Dr. Branagan, I'm going to do one more question from the virtual audience,
Sure.
if that's okay. After diagnosis, what are reasons for additional bone marrow biopsies, if any?
Oh, wow. Interesting question. So maybe somebody who doesn't like to have bone marrow biopsies done, right? I think everyone's different. In general, it's good to do a repeat bone marrow biopsy when and if you progress, because you can develop new mutations, and it's good to know about those mutations. So that's when I think about it. It's never an absolute where you have to. I think you really have to at diagnosis to know you have Waldenstrom's. And then it's really a discussion with your doctor about the benefits of it. If it's a clinical trial, it's very helpful because that helps track the disease, exactly how well the medication's working. So that's how we learn about new therapies. But outside of a trial, there's really different, some different reasons, but that's really the major one. We don't usually do it to see how deep the response is. That usually doesn't add too much because we have that great way to track the disease, which is the IgM, and that's easy just from the blood. Okay, we'll close it there. Thanks, everybody, for your attention.
Okay, so the IWMF values audience feedback, so please complete the survey for this session. For those attending virtually, the survey will automatically pop up on your screen, and in-person attendees can scan the QR code provided for this session. Looks like that in your packet. So right now, we'll go ahead and take a break until 10:45 a.m. Please come back for our stretch and breath break. That's going to happen here at 10:45, and then the next presentation starts at 11 a.m., where we'll discuss current treatment options. Thank you very much.